topic. Get us teed up. Good afternoon. Welcome to Grand Rounds today. I wanted to give you a reminder that we will not be having Grand Rounds for the next 3 weeks, so we will reconvene after the first of the year. Also, as I always do, please remember to fill out the attendance records and also fill out the program evaluations and give us any ideas that you might have in regards to future topics or future speakers. And in fact, I think this topic was suggested from someone in the audience, and I think it's a great topic. Today, our speaker is Ames native and radiologist Dr. David Sosnouski. Dr. Sosnouski did his training in radiology at the University of South Carolina, and then joined the staff here at McFarland and Mary Greeley. Then took a sabbatical, went back and did a musculoskeletal fellowship, and is now back on the staff here at McFarland and Mary Greeley, and he's here today to update us on body imaging. And please join me in welcoming Dr. Sosnouski.
I'm not used to these ear microphones. Okay, good. It sounds like it's working. Okay, so probably a few of you are wondering, okay, he just said he did a year musculoskeletal fellowship, so why is he coming to give a body imaging presentation? Well, musculoskeletal isn't quite as controversial or anything, so the topics I talk about there would be a little bit more boring. But there's, we're going to talk almost entirely about prostate MRI, but there's a lot of new things in body imaging that have been coming up, prostate MR of which is one. And I thought it'd be good just to show people what prostate MRI is, what it potentially has to offer, what some of the controversies are, and just some of the different topics that have been discussed. So whenever I give presentations on almost anything, I always like to start a little bit with the physics behind what we're doing. A lot of prostate MR has to do with anatomy. However, when you're doing MR, it's much different than CT and other imaging modalities. You get a lot more information than just the anatomy of the organ, which you do get fantastic information about the anatomy. But because MR is special in the way you set up your parameters, you actually can even get histological information to a certain degree, but without having a rudimentary understanding of MR physics, it's kind of difficult to explain that. So in general, the way MR works is, I don't want, at the end of this, everybody's probably going to forget anyway, but it might help just a little bit with going through the whole presentation. We all have nuclear spin states in all of the atoms in our body, and they're either diamagnetic or paramagnetic, and I won't go into which elements have which, but hydrogen is what we're imaging with MRI. And hydrogen's a paramagnetic substance. It only has one proton, so it has only one nuclear spin state that in any magnetic field will align either parallel or anti-parallel with a magnetic field. As we sit here on Earth, they're all over the place and it's completely random. However, when you get in a magnetic field such as a 1.5 or 3 Tesla magnet, a humongous magnetic field aligns all the hydrogen protons either parallel or anti-parallel so that you actually get a net magnetic moment that actually is, without any RF pulse or anything like that, is going to be in the parallel direction. So because you have this moment, they're actually, not only are these aligned along the magnetic field, they precess at a specific frequency along that magnetic field, and if you give what's called a radiofrequency pulse at specifically the frequency they're precessing, it'll tip them all into what's called the XY plane opposite the magnetic field and give back a signal. So here's an example of an RF pulse tipping the magnetic moment so that you eventually get a signal that's in the XY plane that's going to give back signal so that you can create an image from it. I'm not going to go into too much detail. T1, I'm sure you've heard these terms T1, T2, all this different stuff. You know, what does that really mean? Well, whenever you impart energy on one of these protons, what ends up happening is it goes into the XY plane and two different things happen. One is T1 relaxation, which is it gives energy back to the main magnetic field or the lattice. That's called spin lattice relaxation. And the other is that the protons actually dephase. They call it T2 relaxation. It should be T2 dephasing. The combination of both those destroy the signal. So initially, right after you give the RF pulse, you have a ton of signal, and it's going to go away either by dephasing or by losing energy to the lattice, which is T1 and T2 relaxation. So here's an example of T2. Eventually, it goes in the XY plane, but they dephase and they lose signal. I don't want to go into too much detail about all this, but they are mutually exclusive processes that we actually do things to alter signal based on these dephasing and energy loss characteristics. So you give this RF pulse, again, just another image to show it's going to the XY plane. What ends up happening is this is the signal I was talking about. It starts with a really strong signal, and just because of just entropy, if you remember your laws of thermodynamics, disorder is always increasing. I think that's the second law of thermodynamics. Well, it's the same thing with nuclear spin states. You put them in it all in line in the XY plane. Just because of entropy, they're eventually going to dephase, because that's what happens. Everything just proceeds towards disorder in general. So this is a very mad slide. It's trying to show both T1 and T2 weighting together, showing the dephasing and the refocusing of the energy to the lattice. Showing both of them together. They are mutually exclusive processes that are happening exactly at the same time, and we try to do certain things to alter the image characteristics based on the fact that the signal is being lost with both of these processes. What do we do for T2 weighting? Well, you give this 180-degree pulse that refocuses the echo. You can see there's the 90-degree pulse, which is that initial RF pulse, putting everything in the XY plane. After a certain time, you give a refocusing pulse, because as they dephase, if you give the exact opposite radiofrequency in the opposite direction, it'll rephase it and give you what's called a spin echo. And the 180-degree pulse, if it's given very rapidly, almost everything will give signal back. But if it's given at a long time point, only things with very little T2 dephasing, such as water, will give signal back, and that's why something like water has increased signal on T2. This is trying to show how you work with T1. That you just rapidly give RF pulses. The way T1 weighting works is everything goes into the XY plane. If you rapidly give another RF pulse, if it's in the XY plane, it won't see that pulse. So only things that rapidly come back to the lattice, such as fat, will still have signal on T1 weighted imaging. This just, again, shows contrast, T1 and TR. Decrease the TR, you're going to increase T1 weighting. And the opposite is also as such. Another graph just trying to show T1 and TR. T2, decrease the TE, you decrease T2 weighting. The opposite's true if you increase the TE, and here's another graph to show that. Again, the only reason I'm going through this is just to briefly show you MR isn't just like CT where you just do it to get an image and it's going to just basically be based on density. What you're doing with all these parameters significantly alters the way the image is going to look and gives anatomic information about what's actually there, because we know water dephases very slowly, so if you lengthen your TE and you see signal there, it suggests to you certain characteristics. Now keep in mind, it's not as simple as just water or fat. Every element or every molecule has its own physical properties, also depending on what lattice it's in. But clearly, there's a large amount of information you gain by just understanding these concepts and how you're altering your scanner to take full advantage of them. So here's what a scanner looks like. In addition to what we just talked about with T1 and T2 weighting, that's actually the easy part of MR. The hard part is actually understanding how we actually create the image. So what you get is only one signal. This is a mistake made even by a lot of radiologists. There is no T2 signal. There is no T1 signal. There is no diffusion-weighted signal. There's one signal that the receiver coil is seeing, and then it uses what's called a Fourier transform to go ahead and decode the signal into spatial information. If we did nothing to alter the way the signal looked in space, you would get one bright dot because everything's the same signal. So you need to go ahead after you've done, imparted energy on these nuclear spin states and they're giving back signal. You then need to alter the signal in a predictable fashion so that at one point in space you speed up a proton and the other point of space you decrease its motion. And so this just kind of shows how you give what's called a gradient, and that just tries to get different frequencies of protons in space so that when the computer gets the signal, it says, oh, wow, look, the amplitude at this particular frequency is extremely high. It must mean that wherever that spatial area is that has protons of that frequency must have a lot of hydrogen protons there. That's how the computer decodes all this information to try to give us an actual image in real space. This is just, again, showing what gradients do. And there's a reason I'm going into this gradients, because prostate MRI, we use what's called multiparametric imaging, and this explains a little bit how diffusion-weighted imaging works. So this just shows that with these gradients, if you have what are called high K values, which are high gradients, you're going to get a lot of spatial information, but not much contrast because you have really, really high frequency signal with those. And then with low K values, you get more contrast with less spatial information. This just shows a gradient echo sequence. You don't have a spin echo, but with a spin echo sequence, you have that 180-degree refocusing pulse. And again, obviously the point of this is not to understand all about MR physics, but just to get a rudimentary understanding of how things work. This is a pulse sequence timing diagram of how everything works with the 90-degree pulse with rephasing pulses. So one of the only reasons I got into this is diffusion-weighted imaging is hot in the literature, whether it be urology literature, radiation oncology literature, or radiology literature. Everybody's talking about diffusion-weighted imaging, and ADC maps and actually trying to quantitatively analyze is something likely to be cancer or not. What diffusion-weighted imaging is that you give a really long gradient in one direction, flip that gradient, give it in the other direction, and something that moves very minimally in space will no longer give back signal because it's moved. And the computer only predictably understands what it predicts should be the precessional frequency. So it's assuming things aren't moving. So if you purposely try to create these gradients, anything that moves a little bit will not give back signal. That's called diffusion-weighted imaging. And then the other thing, this is a little bit easier to understand, dynamic contrast enhancement. That just basically means we give contrast with the prostate. We do this with breast imaging too and other modalities. And at regular time intervals, we just go ahead and keep imaging the prostate, and we try to get an idea of how rapidly whatever we're looking at takes up contrast and possibly spits it out, which is called rapid washout, which is commonly seen with cancer, whether it be in the breast or in the prostate. So this is just a timing diagram. Black is cancer, red is just a normal prostate tissue. You can see, in general, cancer will take up contrast fast and release it because it has a lot of neovascularity. And here's some examples of dynamic contrast enhanced imaging where you use color maps. So basically what happens is you basically you do about 15-second image acquisitions of the prostate right after you give contrast. And red is to denote areas that have rapid washout because it's really, really difficult to evaluate things like this looking at the myriad of, and I'm sure the urologists, radiation oncologists that have seen our studies have seen we probably have, I don't know, maybe 40 post-contrast sequences that we really are doing to try to get this, and you need certain software to be able to show these color maps. So prostate MRI, let's get to things that are a little bit more fun than talking about MR physics. Everybody knows it's a problem. 200,000 men diagnosed a year, 30,000 die. A lot of men get it. 1 in 35 will die. There's risk factors. You can see here what those are. And basically, there's one thing that's interesting in prostate MRI is clearly risk is an important thing. In all cancer, it's important, but in determining what you're going to do, it's a little bit different, in my opinion, than when you look at breast cancer and all this different stuff. I think a lot of times with breast cancer, you just see that there's a cancer, you biopsy it as a cancer, and I know that there are differences in what we do based on histology and everything, but nowhere near what it is with prostate MRI. There's a big difference between having a Gleason 3+3 and a Gleason 5+4, as everybody knows. So we're always trying to categorize what a patient's risk is. And as you'll see here, nowhere in here is their MRI, so we'll get into where does MRI fit in. But right now, we basically generally call people, either low risk, intermediate risk, or high risk. And you can see right there using PSA, Gleason score, and then the clinical stage, which that's where, in general, people think that prostate MRI might be helpful is with the staging. But I'll show you. And I talked to Brad about this in one of our meetings. I actually think some of its usefulness actually is not really so much the staging, but other things that you won't even see in slides like this. And I'll show you examples of that. So this is just going through different things that you might do for treatment. It's all over the place with treatment. No immediate treatment, low risk, monotherapy, meaning you just choose prostatectomy, radiation therapy, high risk combination therapy. And this is just staging. The reason I'm going over the staging is because with prostate MRI, the majority of what you'll read in the literature will be all about staging. How accurate is it? How sensitive is it? How specific is it? Prostate MRI, the majority of what you'll read about or what the importance is about extracapsular extension and does it invade the seminal vesicles, because that takes a patient to being T3, and by definition, they should be high risk, and it might affect what the decisions are as far as the treatment's concerned. The rest of the staging, the nodes are important, but it's not the best for looking for nodes. Really, it's the extracapsular extension and the invasion of the seminal vesicles that it's mostly used for. And I won't go over the whole staging here when you go through the whole system, but that's what it is. So I like this slide. I always talk to people about, has anybody here heard of the Wells criteria? You probably have. I'm a radiologist, but for pulmonary embolus. One of the things I love about the Wells criteria for pulmonary embolus is that it goes through all the different things, O2 saturations for the patient, all the various clinical data you can have, and then it gives all these scores for whether or not you should get a CT scan to look to see if the patient has a pulmonary embolus. And I think a score of 3 is positive, and in there it has clinical suspicion, 3. So, I mean, that's ridiculous. Clearly, you're going through this algorithm for a reason because you have clinical suspicion for pulmonary embolus, and then in my opinion, based on the Wells criteria, everybody, I guess, should get a CT for pulmonary embolus if that's the way you're going to look at things. Well, I'm saying that kind of in jest, but this is what happens with prostate, and I'm sure everybody, the urologists, radiation oncologists in the room will agree. There's a lot of debate. Look at this, active surveillance for everything. So, and that's true because a lot of it is clinical. I mean, there's a big difference between a 90-year-old that, has a Gleason 3+3 versus a 55-year-old that has a Gleason 5+4. All these different, there's such differences in the clinical scenarios. But you can see there's every single option for almost every single stage. So if anybody's, I think the slide just exemplifies, why there's debate. So what matters with prostate MRI? So I spent a month doing this, and we probably read about 4 prostate MRIs a day. And the guy I worked with, it was more than one person, but one of them was just fantastic with reading these things. He actually said one of the most important things you actually get out of a prostate MRI is actually the size. You should always put the size of the gland in your report. The reason being, a really good reason to do a prostate MRI is negative biopsies with an elevated PSA. Well, let's start with a 300 milliliter prostate explaining why the PSA might be elevated. So, you don't want to go down the road of, oh, I'm not finding the cancer and all. You kind of lose the forest through the trees. So mentioning the size of the gland is very important. And then, of course, what matters, people tell you extracapsular extension, determining if that's there or not would matter because that takes you from stage 2 to 3. Keep in mind, I'll say a few things about treatment. This is just where I was at, what they did. I'm sure everybody has their own way of with radiation oncology or surgery, what they do. But going from stage 2 to 3, a radiation oncologist, at least at the institution I was at, it would change things from, giving just IMRT at 79 gray, you'd also give external beam radiation to the entire pelvis at 45 gray. So that was the idea, and that's fairly well established in a lot of the literature I've read, at least for radiation oncology purposes, that the extracapsular extension will affect things in that matter. And also it'll determine if you need hormone therapy or not. Seminal vesicle invasion is also important. It incurs a much worse prognosis, so it gives you information to give to the patient. You might need a longer course of therapy, and I don't know if anybody does this here, or even if this is supported or not, but in theory you could give intensity modulated radiation therapy possibly to not just the seminal vesicles, but also lymph nodes. That in theory you might want to do that. So what might matter? I say might, but to me this actually is what, when I was going through this whole month, what actually seemed to matter the most. Negative biopsy but elevated PSA. I'll show you some pretty fantastic examples in just 1 month that I was there, and I'm sure if I did this for a whole year, we'd have a ton of them, where the indication would be negative biopsy, elevated PSA, and you see a really nasty looking cancer in the anterior gland. I think that's a great indication for prostate MRI, and it's kind of funny because you don't see as much written about that. I mean, there's a little bit written about it, not near as much as about the staging, but to me, that's a fantastic reason to do it, and I'll get into different case examples. Another one, is there cancer that was not biopsied in the central gland that could change risk categorization? Example here would be, patient has a PSA of 35 and you have a Gleason 3+3, and you really think that there might be something worse than what you're actually doing. You would consider active surveillance based on your biopsy, or I mean, I know you might not, but the MRI suddenly shows, wait, that was the tip of the iceberg. There's much worse cancer somewhere else. That's another probably less strong indication than the first one, but it's something that I saw a few examples of, and it helped in a few cases. And then there's other few things like, is bowel in the radiation field? That can sometimes be important to the radiation oncologist. So for the non-imagers and people, the people that don't deal with this all the time, this is just a little bit about prostate anatomy. You can see that the prostate is basically divided into 3 things, or 3 different zones based on the craniocodid axis, which would be the base, which is nearest the bladder, the mid-gland, which is number 2 up there, and then the apex, which is the most inferior. And what you can see color-coded there, peripherally is the pink peripheral zone, which is actually where about 70% of prostate cancers come from. The blue area is the transitional zone, and the yellow area is the central zone, which we can't distinguish based on imaging, so we just call it the central gland, and about 30% of cancers come from there. The most anterior, really red area, or kind of reddish pink area, that's called the anterior fibromuscular stroma, which really doesn't have the ability to have adenocarcinoma of the prostate because it doesn't have prostate epithelium. But I mean, in theory, you could get a stromal tumor or something, I guess. It's not as important. Here's just an example of an MR Scout that might be done to start setting up your axial images. And here's some of that prostate anatomy you can see on the MR based on the image I just showed you, going from the base to mid-gland to apex. Almost every single MR we look at is going to have BPH, so consider this normal. It's almost unheard of that you actually see a normal prostate in, you know, a 25-year-old man on MR. So I actually have never seen a normal prostate. They're always going to have BPH, and they're always going to look like this. And that's important because usually there's not really much of a concern about the peripheral zone because the urologists know about this. They got it in their biopsy because the rectum, which is the bottom of your screen there, is right where the needle will come in, unless you're doing a transperineal biopsy, which you'd be more likely to get more of the apex of the prostate. But the reason the central gland is somewhat important is, as I mentioned before, that might explain the negative biopsies with the persistent elevated PSA that can't be explained. And so we have to understand it when we're imaging. Prostate cancer and T2, I talked a little bit about MR physics with you guys. T2 in general, it's water is bright on T2, and the peripheral zone has a lot of water in it. So in general, usually prostate cancer will be dark on T2. That's really important. It's one of the three facets of multiparametric imaging, which all articles will talk about multiparametric imaging. One is T2 weighting, and you see decreased T2 signal. So this is an example of prostate cancer here. Left is axial, and on the right is a sagittal image. This is diffusion-weighted imaging. Remember that crazy slide I showed you where I tried to explain that if you put the gradient in one direction for a long time and in another direction for another time, if a proton stays in the exact same location, it won't matter because you'll dephase it and rephase it exactly the same, and it'll give back the same signal. So something that does not move much will end up being bright on diffusion, and actually we use ADC map, which is the inverse in dark, and that's a really difficult thing to explain. But the point being is what you see is dark on ADC map means that water is not moving. In the normal peripheral zone, there's free flow of water. In prostate cancer, lymphoma, other cancers, this isn't unique to the prostate, but it's utilized quite a bit in the prostate, you restrict movement of water because there's tightly packed cells, and water cannot just diffuse throughout the cell membranes, and you get what's called restricted diffusion, which shows up as dark on the ADC. So that's the second part of multiparametric imaging, and the third part is the dynamic contrast enhancement, where you get rapid wash in, wash out. It'll show up as red on these color images. So in general, you have three different landmarks to kind of look for when you're trying to evaluate, is something cancer, is it not, or where is the cancer going? If it fits all three, it's going to be likely that it's prostate cancer because there's very few things that'll do that. Of course, there's some quandaries that you know it's not quite that simple, but that's why they call it multiparametric, using all three of these. So here's an example of one would be a quandary. You might look at this with just the T2 and say, oh, well, on the left, that's not prostate cancer. Things don't always read the book. It can have increased T2 signal. This is an example of that from the literature. And then you can see no one would look at that color map and say that's normal to have that much rapid washout asymmetrically all throughout the prostate. And for all we know, this goes into the debate of the usefulness of prostate. For all we know, there was a biopsy proven 4 + 4 there anyway. I don't know. But I'm just trying to exemplify for you. The reason you do multiparametric imaging is because it won't always fit all of those criterion. And here's just an example of a dark central gland that's prostate cancer from the literature. And again, this is that same case showing the rapid washout, and it shows the effectiveness of the color map to try to identify things that won't necessarily show up with T2. Here's an example of extracapsular extension. Posteriorly and to the left, you can see the confines of the prostate, and right there you have some going beyond the capsule. This is one of considered the most important things for us to be evaluating for is extracapsular extension, because again, this takes us to stage 3, which will place the patient at high risk. But again, like I showed with that slide, what does that mean? That's kind of up to the clinicians involved, because clearly that slide showed that there's every kind of treatment for every different stage, which I know it's not that simple, but the slide shows the controversy that can happen with these things. And so here's seminal vesicle invasion. That would take you to stage 3B, further upstage the patient, worse prognosis, again, maybe a longer course of radiation therapy, etc. So I'm going to go through some cases, and I want to let you guys know, I mean, like I said, I did this for a month, or about 20 days total, 4 cases a day, so that's about 80 cases. And so this is just so it's not like I spent a long time and only pulled out of, the remote archives of the prostate MRI files, the very few cases that are interesting. I tried to make this more of a real presentation about what you guys can get out of this or what you can't get out of it. So here's an example of a case here, and hopefully these videos will work. Yep, it looks like they're working here. So here's an example of a T2 weighted image. And you can see you certainly have BPH, like you always will. But if you look over here, this should be the peripheral zone all the way out here, and it just kind of stops. So here's that ADC map I was talking about that gives us information about diffusion weighted imaging. And look right there, it's dark right there. So now all of a sudden I have two of the different parts of the multiparametric imaging that are positive for cancer in this region. And this here is a T1 weighted image. And it's going to come up eventually. And I only showed this because usually we don't have to use it, but it's important to have because you might look at this and say, wait, is that seminal vesicle invasion? Is that, what is that? Because you look at how asymmetric the seminal vesicles are. Hemorrhage is often, or usually, increased signal on T1. So in this case, the T1 just helped to prove that what's on the right is actually hemorrhage because it has increased T1. So the reason I'm showing that is just to show, again, this is an example of how you're getting more than anatomic information with these images. So this is a left peripheral zone cancer that was stage 2, did not have extracapsular extension, and then there was hemorrhage in the right seminal vesicle. So here's an example of what I was talking about that I think are useful for these studies. This is a patient, we got these indications all the time, negative biopsy. That's almost definitely going to be a cancer there in that left anterior gland. And then you go to the ADC map. Look how dark that is on ADC. Now, just to let you know, I'm not going to go over this literature because I don't have time to go into everything. What they're doing a lot of studies now on actually getting the quantification of the ADC and seeing how well that correlates with eventual histology, and they're having pretty good results with it. And you guys can see with almost all of these cancers, you're going to have dark ADC, and you can actually, the ADC is actually a measurement of the slope of the decrease in signal with increased B values. It doesn't matter what that really means, but you can actually get a quantitative measurement from these, which we're not doing here, and the majority of places aren't, but that's what's in the literature and in the research right now, trying to predict. And this is what the initial research is can an ADC be correlative with a Gleason score? So that had a repeat biopsy, and it was a Gleason 4+3. So this is exactly what I was talking about when Brad asked that question in tumor board, you know, what do I see as the usefulness? I think there's a lot of debate out there. This one to me is just useful in my opinion. If you have someone that keeps getting negative biopsies and something like this can happen, I think that MR did make a difference in a case like this. There might be arguments against it. I don't know if maybe management could have been done differently. But in this case, I think that it does help. Another example here, negative biopsy. So on the left, you have your T2 weighted imaging. And on the right, you have your ADC map. Look how dark that is there anteriorly in the gland. Again, like I said, the anterior gland, in my opinion, is one of the most important things for prostate MRI as far as what we can provide people, because again, from the biopsies you usually know quite a bit about what's going on in the periphery. So this one had negative biopsies. We said there it is in the anterior gland, goes back for a repeat biopsy, Gleason 4+4. I mean that's a serious cancer that was missed on the initial biopsy. Case 4. So on the left is T2. On the right, you have the ADC map. This is more subtle. You have left anterior mid-gland, right there, you see the restricted diffusion. You can see the usefulness of this diffusion-weighted imaging. And this is an example of another one that had a negative biopsy. And I actually don't have the results for this. I had the results for the other two. We might be wrong. That might not be cancer. But again, it's a negative biopsy. What do we do with this? Active surveillance? Yeah, I might kind of want to know what the histology of this would be, because a prostatectomy might be curative in this patient. Do you do radiation? That's a debate. Whatever the patient wants, prostatectomy versus radiation, and then it's more complicated than that. There's multiple different forms of radiation you can have. That'd be hard to biopsy. Do you want to get an MR-guided biopsy? Very few institutions are actually doing MR-guided biopsies. Where I was at, they were not doing them. I've never even seen one done. I don't even think at the University of Iowa they're doing them right now. But what happened is usually troubleshooting. Sometimes in a case like this, if the PSA was high enough, they'd go to prostatectomy and prove it, and they'd have very, very good results. I know it sounds shocking, but they would. And so this one I don't have the results for, though, so I'm not saying that this is correct, that that's a cancer or not. Here's an example, left apex lesion, 3+3 on biopsy. And I don't see anything in the left apex, and we'll get into in just a second how prostate MRI certainly cannot be used for screening. But look at right anterior. That's almost for sure going to be a cancer, almost for sure. So now we're dealing with someone that potentially could be on active surveillance. A lot of people with 3+3 would choose that. Boy, if it was me that had a 3+3 and the MR showed this, you know, if I was already choosing to get a prostatectomy anyway, it probably doesn't matter. But I think if someone's going to choose to do active surveillance, that's another thing. Active surveillance, what that means is you're just not going to choose to have radiation therapy, you're not going to choose to have a prostatectomy, you're not going to choose to have anything other than watching the PSA and the clinical exam, assuming prostate MR is not a part of this. If someone actually chooses that, this is an example, in my opinion, where the prostate MRI might sway you a little bit more to a little bit more active management. So again, I don't have histology on this. I was just there for a month, you know, and I wanted to give you guys cases that I actually had the results, or that I actually was actively involved in, not come here with every perfect case. So I'm very, very confident that that would have been cancer, and this was brought up at a tumor board, and that patient ended up getting radiation therapy for his 3+3 that he might have gotten active surveillance for in another case. So here's another case. This is coronal and sagittal imaging, so you're going to have to orient yourself a little bit. Here's the prostate right here, and as I'm going back, there's the seminal vesicle. You'll see right there, the seminal vesicle is normally bright on T2. Definitive seminal vesicle invasion is you actually have decreased T2 signal within the seminal vesicle lumen itself. It is true, this is just thickening of the wall, which is a little bit more debatable. You'll get into a lot of research articles that'll give categorization of 1 through 5, 5 being definite, 1 being absolutely not seminal vesicle invasion. I'm not going to go into the detail of that. This is very likely to be seminal vesicle invasion, and it did end up being so. But you can see right there where the invasion is. So, I'm sorry, I did not know the results of this. So, but you can see how, in this case, with seminal vesicle invasion, it could potentially affect results. And I'm going to go into, with some of the literature, how we should be interpreting these things as far as specificity and sensitivity is concerned. But I first want to just show you cases so you can see what prostate MRI is. Another example, left is axial images, right is coronal images. And you can see again, just asymmetric dark signal at the base of that left seminal vesicle immediately adjacent to the cancer, so very likely to be seminal vesicle invasion. Here's another case. Oh, I'm sorry, this is the same case, I apologize. What this on the left is when we deal with the diffusion weighted imaging, the right is the ADC map that I've been showing the cancer of the prostate the whole time. On the left is actually the source image for an ADC map, which I won't go into the details of that, but if you go to what's called the highest B value, which is the steepest gradient, lymph nodes that persist are a little bit more suspicious, and you can see in this left operator region there's a suspicious lymph node. I don't think MRI is very good at all for lymph nodes. However, if a surgeon says, hey, if I'm going to go in here and sample nodes, where do you think is the most suspicious? Hey, I can tell you, in this case, I would put my money in the left operator node if anyone was going to be positive. Take it for what it is. If you're interested in that, great. If not, there's no standard of care. This isn't a part of an algorithm anywhere. It's just some added information. There's another case here. And this is a floored seminal vesicle invasion. You can see the bases of the seminal vesicles there are completely involved. Right there. And then interestingly enough, or actually I think it's the last case, the bowel looks okay here. Oh, there is a little bit of low-lying bowel. If a radiation oncologist needs to know there's bowel that potentially could be in the radiation field right down here if you're going to radiate the seminal vesicles. That was one of the reasons I showed this case. It's not just for people who have a native prostate. People that have been treated and have PSA, and this is something I learned. I was unaware of this before I left, but this is just oh, sorry about that. This is just two examples that we had. This is the first of two, where this person happened to have brachytherapy, and you can see here is the T2 weighted imaging, and you notice there's kind of a gap of the brachytherapy seeds down here in the prostate. So the patient has an elevated PSA. Now we're getting to the post-contrast images and where that can help. In a patient that's had a prostatectomy or brachytherapy, you almost have to entirely rely on the post-contrast images. All that stuff with ADC map and T2 weighting goes away. Here, it's very likely there's a residual cancer there. You can see it's really bright at 1 minute, and it kind of washes out at 10 minutes. So what does this matter? There's not much therapeutic choice other than maybe cryoablation at this point. Someone else might add something in there that I'm unaware of, but it might give you some information you need if you want it. And here's an example of a person with a prostatectomy with a rising PSA. And you can see right there, enhancement right there, and right there, significant amount of enhancement in the prostate bed. I will say, it is difficult to know is this prostate cancer or residual prostate tissue that is left after the prostatectomy. I've actually never seen a prostatectomy, been in the OR to know how likely is it that there's going to be prostate tissue left there or not. However, rising PSA, my presumption is that that's going to be residual cancer. But this is another case where we did not have the histology. Okay, this is a case at McFarland. So we've been doing this here, and I got permission from this patient to show this. So this is, in my opinion, one of the usefulnesses of prostate MRI. And you can see right there in the right anterior gland, you have a mass, completely asymmetric. The BPH, just so everybody knows, is right in here. This is the peripheral zone right there, turning into a mass that completely distends the anterior fibromuscular stroma beyond the capsule. ADC is correlative, it's dark. Here's the post-contrast, it completely enhances. So this is absolutely consistent with a prostate cancer with, in my opinion, extraordinarily high suspicion for extracapsular extension on the right anteriorly. And just so, in case you're wondering, oh, well, just to remind you what normal looks like, the middle one and the one on the right, that's what someone who does not have extracapsular extension looks like. On the far left is what someone who does have extracapsular extension looks like. And the reason I'm showing this case is, and I'll get into this a little bit later, the importance of prostate MRI is this: you want to be specific. We don't want to be calling this subtle extracapsular extension that might not be there, might be there, and preclude a person from a prostatectomy, based on very subtle abnormalities. This is what, in my opinion, we should be looking for is something that's obvious that could change a patient's management. And in this case, I think it probably will. I chose mostly articles from urology literature, and I actually stopped in February when I was on this rotation. And the reason I did that is because in the radiology literature, everything's fantastic and all this different stuff, So it's I think if you're going to try to make any argument, it's better to go to a little bit less biased literature than the people that are developing the modality and trying to get published by showing what they're accomplishing. So I apologize. Some of these studies aren't the best, but I think it gives us the most unbiased way of looking at this. So the first study here is from 2010. And you'll find a lot of these, we don't have a large cohort of patients. And Brad was telling me about it. You were telling me about a study that I apologize, I was unable to find it, and I would love to see that. That's probably more recent than February of 2013, and maybe you can bring that up at the end of this talk. But so some of these are just from before that time. At this time, there was no real large, double-blind study or anything like that doing prostate MRI and getting histology. So a lot of them are something like this, where patient gets a prostate biopsy, and the biopsy shows whether or not there's going to be unilateral or bilateral disease. 88% patients were presumed to have unilateral disease on biopsy, and what they're claiming here is that MRI showed cancer in 63 biopsy-negative specimens of that were biopsy negative. The MRI showed it. The unfair thing about this is just that, in my opinion, you might have had a biased approach to how you're looking at this retrospectively. Of course, you can just start calling cancer all over the place. But again, this is from the urology literature, and so their assumption is that prostate MRI is useful here based on that premise, which I would probably disagree with this study. I don't know if it's the best. And then what they say is that extended prostate biopsy does not show accurate information on prostate unilaterality. and that you should do prostate MRI to try to find out who might need hemiablative focal therapy for prostate cancer. So that's one example of an article here. Another article, MR-guided biopsy of 68 patients with negative biopsy and PSA greater than 4. This is a little bit more useful because this is what I was talking about. Is an MR going to find something in people that don't that have a negative biopsy? And again, I was talking about a PSA of 25. We might get into a lot of danger if someone who has a gland that's 200 milliliters has a PSA of 6 and we're doing a prostate MRI and getting all excited about what we think might be subtle cancer all over the place. I understand where the quandary comes with MRI. And that's where we all use our thinking caps before we order these studies as far as what the appropriateness is or not. But they use PSA of 4. And of course, if you used it higher, you'd have much higher specificity. So 40 of the 68 found cancer that was eventually biopsied by MR, and 37 supposedly were highly likely to harbor clinically significant disease. And this is from Urology. They said that it should be considered essential for patients suspected of harboring malignancy that have had successive negative biopsies. This is another study, effective MR in 60 low-risk patients. This is what I was talking about with active surveillance. So this is the patient that's not choosing, they got a Gleason 3+3, PSA of 7. They're choosing not to get a prostatectomy or radiation therapy. They want to go on active surveillance. This one I kind of agree with, where prostate MRI is somewhat useful. They showed that in 22% of MRIs, they'll show what they think is a significant cancer, 1 centimeter or greater, meaning that they think you probably should not be on active surveillance. And of those, 10 were actually reclassified, according to the study, at a biopsy after a year. So nothing was done initially because it was just, they said, okay, all these people that chose active surveillance chose no treatment. We're going to do an MRI and not do anything based on the MRI, but a year later we're going to see what your PSA does and all this different stuff and see if you actually get a follow-up biopsy that shows that you have a problem. So what this showed was 10 out of 60 patients would, in my opinion, have been affected by having an MRI because they chose active surveillance. And then of the 23 where the MRI was normal, 2 are reclassified. So that means it is true MRI still might miss some that are reclassified, but nowhere near as many as they'll catch. So, and then, again, this is from urology literature. They showed that if you're going to choose active surveillance, MRI might reveal an unrecognized significant lesion in 22%, and of which will be reclassified in about 18% of patients. And I'm not going to go into this about the histology they showed from that same paper. Here's one surgeon for 10 years, evaluated all prostate MRIs that ended up going to prostatectomy. What's interesting about this study is they did MRIs, and clearly some people probably did not get a prostatectomy because the MRI showed obvious extracapsular extension. And this is the problem with a lot of these studies is so now all of a sudden your cohort of patients is just patients where an MRI probably did not show significant extracapsular extension, and that's why they chose a prostatectomy. So again, I understand that I don't think this is the best study, but everybody asks questions about why should we do prostate MRI, and everybody gets excited about results from a certain study. I'm trying to show how some of the results can be erroneous. So like I say down here, it selects out many obvious stage 3 cases. And of the 110, so they do have results, 90 did have organ-confined disease, and of that 90, 83 were correctly identified as being organ-confining based on MRI. Of the 7 incorrect cases, remember how I said they always have these like 1 through 5 grading systems for if you're how suspicious you are that there is prostate cancer. Only 1 was definite. And here's an important thing, I think. It's pretty unusual for us to say there's definite seminal vesicle invasion or extracapsular extension if we're reading it, in my opinion, correctly. And if that's the case, as this article tries to make the point, really only about 1 in 90 should you be wrong. And so what does this all mean? It means that if you're reading it with the strictest criteria, meaning I am not going to call extracapsular extension unless there is just obvious bulging of the capsule, obvious tumor going beyond the capsule, not just this subtle hazy stranding of the fat, which still might be extracapsular extension, but I'm only going to call it if I'm definite, then only 1 out of 110 patients from the original MRI would be excluded a prostatectomy by falsely calling extracapsular extension. That's bad. You don't want to do that. You don't want to say, you don't want to get into all the minutia and say there's extracapsular extension when there's not, because then you might be precluding the person the prostatectomy as an option for their therapy. But on the downside, and we all have to accept this, 11 of the 110 would have been correctly excluded from surgery, and the organ confinement rate would increase 82 to 91%. So that's good in theory, that you would have precluded 11 of the 110 patients and increase your organ confinement rate. So here's the quote from that. The main benefit of prostate MRI is its ability to detect advanced disease missed by conventional clinical staging. Our results are comparable with those of previous reports for endorectal coil. And that's my verbiage there, not there. I'm just trying to say you should err on the side of specificity to prevent false positives for extracapsular extension if someone's going to be ordering these studies. And so here's just a review of dynamic contrast MRI. I'm just going to go to the conclusion. It can accurately identify intraprostatic cancer, foci, possible applications for our guidance, biopsies, selection of patients, watchful waiting, focal treatment planning. Another one with MRI and biopsies. This is actually a negative one for MRI that I agree with. It says, what the gist of this is that while MRI can find cancer, there are a lot of cases of cancer that are caught on a biopsy that MRI just totally doesn't see. And I see that all the time. During that month I was doing this, and even here, there's a lot of times I'll look at you guys' biopsy reports and I'll go, wow, it was positive there on the left, and I'm looking at the MRI and it's not there. So that should not be the purpose of this. It's useful if it's a negative biopsy with an elevated PSA, because if MRI catches it, it's going to be pretty likely that it is cancer, if it fits, especially if it fits all three components of the multiparametric imaging. However, certainly there's zero evidence that MRI could eventually be done as a screening tool. And then that's just basically what they're saying here. So I'm going to do this really quick. I did do a little bit more in prostate MRI, and I apologize. I know this is supposed to be a prostate MRI talk, but I do have the audience of multiple physicians here who might eventually be ordering studies and might be interested in some of the other things I learned. This will be very quick. One of the newer things that's being done right now is MR enterography. And we currently are doing that on our 3 Tesla magnet and our 1.5 we have here. We are going to be getting a new 1.5 Tesla magnet with body imaging. Actually, 1.5 Tesla has a lot of advantages actually over 3 Tesla. And this is an example of what it gives you. It's a patient with Crohn's disease, diffusion weighted imaging, increased signal. We do it for this in addition to prostate and a bunch of other things. You have just subtle increased signal on T2, and then you do the post-contrast imaging, and if it slowly enhances, that suggests it's fibrotic, as opposed to being edematous, distal, small bowel. And here's an example of the kind of things that we can't do currently with our scanners, but you can do if you get a very, very good 1.5 Tesla scanner. You can basically almost replace small bowel follow-throughs. You can do these ultra-fast dynamic FISP images. The reason at 1.5 T you can do this much easier than at 3 T is because the ability to move a gradient is much, much enhanced by having a lower field strength. If you increase the field strength, it's really difficult to move a gradient. And to be able to do things this fast, you need a low field strength magnet. Just another example. I just want to show you some of these images of what can be done. Again, it's almost like a virtual small bowel fall through using MR. And you can see in the top right, nothing's moving there. So it gives you all the same information with zero radiation. And then I'm sure our technologists will love this one. But you can also do defocography, looking for things like a prolapse. And I don't know if this is going to. So I'm not suggesting we do these things, but I just want to show this to you guys because there are a lot of applications we can have with a very, very good 1.5 Tesla magnet. Not only prostate MRI, which also is done on 3 Tesla, and there's a lot of data about that, the difference between 3 Tesla and 1.5 Tesla, but there's a lot of other applications that can be done with a 1.5 Tesla magnet that we certainly can do better with in the future. So that's all I have for now. Does anybody have any questions? Yes? A prostate MRI? Yeah. That's a great question. No, I have to. A lot of times I don't know the cost for things because it's so variable with Medicare and with various other things. My guess is it would be something in the realm of like $800. It would just be an MRI of the pelvis, not abdomen and pelvis. So, but that would be the code. Yes. I don't know, to be honest, because I've never seen one done. And I've actually tried to look that up, and I've seen that you use an endorectal coil to place the needles in. I've never seen one done, though, so I don't know. And it's a rare procedure to do. It really is. I'm sure they do them at Mayo, would be my guess, but it's just not. I don't even know if in Iowa if anybody's doing them, to be honest.
So,
yes, yeah. It's it would be a non-ferromagnetic substance that I don't know the exact composition of it, but yeah, it would be a special needle because we do MR-guided breast biopsies too.
So, David, do you see clearly a change in standard of care coming
with prostate
MRI?
MRI?
Prostate MRI.
Well,
MRI.
here's the problem with it. No one has really answered that question about what is the algorithm. So I can just give opinions. A prostate MRI is always useful. However, everything's always useful. So that's what the problem is, and that's why I asked him about what the cost is really important. Do we really want to be doing an $800 test on everybody that, all comers? Yes, to answer your question, I do think it can change not just the standard of care, but certainly management. For examples that I showed here, active surveillance. You think that you have a Gleason 3+3 and that's it, and there's nothing else there, and then you see on the prostate MRI that the area that's biopsied you hardly see, but that's the tip of the iceberg. There's something much worse, and you've just chosen what would be a therapeutic option, which is prostatectomy, and it still is standard of care is still fine to be a prostatectomy. That's what the problem is. Standard of care, like that slide I showed you, everything is standard of care here. That slide showed you have every option for almost every single risk stratification. So I don't think, because everything is within the standard of care, I don't know how much it'll change that, but it'll certainly, I think, could swing opinions on how things should be best managed. Like, for example, like that thing with active surveillance or the negative biopsy where you're not seeing anything, and then the MRI finds the cancer, or obvious extracapsular extension or obvious seminal vesicle invasion. So yes, I do think it'll change the way we do things in certain.
How long does it take to do the MRI?
Less than 30 minutes. It's probably about 20 minutes, or no, maybe 25 minutes. Thank you.